Welcome back to everyone to the afternoon session on the first day. We begin this session by hearing from a person who has dedicated his life and career to humanitarian service. It is Dr. H. Sudarshan, who is the founding secretary of Vivekananda Girijana Kalyana Kendra and the founding president of Karuna Trust, which is based in Bengaluru in Karnataka. He has asked me to give a very brief introduction, so I will keep it brief. He is a medical doctor by training, but he has spent the last 45 years serving tribal communities in Karnataka and also taking up rural development projects in various states in India through the Karuna Trust. His work has been recognized through many awards over the decades. Most notably, I'll just mention, he received the Padma Shri from the Government of India in the year 2000. And he shall speak on integrated rural and tribal development activities across India in service of the marginalized and the underprivileged.
Respected Atmapriyananji Maharaj, all the monks, speakers, and faculty members, and my dear students. It's a great honor to be in the midst of you this afternoon. Only thing, it's after the lunch session. I will try to make it very interesting to you, not to make you fall asleep. My subject today is, instead of speaking about my action, I also want to give the background of my, it's basically a philosophical status of doing humanitarian work. So it is a bit of a life story, which is related to how my philosophy was built on, based on that life story. First of all, I was born in a cowshed. My mother gave birth to me in a cowshed. She had a choice to go to a HAL hospital, but she preferred to deliver at home. And as usual, I think it's a custom all over India. They don't deliver at home. They usually prefer to deliver in the cowshed, where it is easy to clean probably. So I survived. I have much better immunity than others. Why I'm saying this is, today my work is, we are giving safe deliveries to 10,000 mothers every year. That's how my life is related to that. When I was 12 years old, my father had returned from England, and we walked to my aunt's place in a village. And he was 42 years. I was 12 years old. He probably had a massive heart attack, and I had to help. I was the only son, helplessly watching him die. So that day, I didn't weep. I made a firm decision that I will become a doctor, and rest of my life I will save lives. So that was the background with which I wanted to become a doctor. So I studied hard. I got good marks. I was in the first 50 in Karnataka and for the Bangalore Medical College, which is the best medical college in Karnataka. But unfortunately, my village school gave me a double promotion. I didn't study third standard. I was promoted from second standard to fourth standard. So they caught me I had to complete 16 years by October 30th. I was completing it on December 30th. So 1 year I had to take off. So he said, next year you can join, but this year we cannot give. So I worked in a flour mill. My mother had to bring up 5 children, and it was hard. So I used to cycle from Bangalore, one part of Bangalore to the northern part of Bangalore. And I used to earn 110 rupees. And the entrance fees for my Bangalore Medical College was 3 months' salary of that. Now, this was a time when one of my friend took me to Ramakrishna Ashrama in Basavangudi in Bangalore. That the idea of becoming a doctor was there, but the idea of becoming a doctor to save lives for the poor was by Swamiji's message. What was basically goodness as a value, to be good and to do good. To do good was there in me to a certain extent, some sort of passion to do that. But Swamiji gave a spiritual direction to that. So after my graduation, I was inspired by several monks, senior monks of the Ramakrishna order, and it was taken for granted. As soon as I finished my internship, I joined as a brahmachari in Mayavati in Almora district, and then I was also in West Bengal here in PPTC here. Gambiranji was the general secretary. I was sent to Seva Pratishthan to get trained in laboratory technology and radiology. So I came and started in the Belur Med dispensary, the X-ray unit and the laboratory. Established the laboratory. This was in 1975 to 78. I worked there. Then my mother became ill, and with the blessings of my Guru Swami Vireshwanji Maharaj, I went back to Karnataka and started my work in a tribal area. So rest of my philosophical things I will tell you at the end of my talk. So very briefly, I will take you through the journey which I have passed through. I'm just sharing some of these thoughts. So as you know, the indigenous population in India is about 8% of the total population, and most of them are in central and northeastern India. For those who don't understand scheduled caste versus scheduled tribe, scheduled caste lived with the so-called civilized world, and they were oppressed by the upper caste. But in the scheduled tribes, they lived away from the caste system and lived independently. So I feel they have a better confidence, faith in themselves. I have also had the unique opportunity of large tribal populations and also vanishing primitive tribes also. So we found Vivekananda Girijana Kalyana Kendra as I was inspired by Vivekananda in 1981. And these are the pictures of the BR Hills. BR Hills is a junction of Eastern and Western Ghats. And it's a transition, the flora and fauna have transitioned from Eastern Ghats into Western Ghats. It's a 540 square kilometers. Now, it used to be a wildlife sanctuary. Now it's a tiger reserve. The people living there are called Soliga tribal people. They're also called children of bamboo. Sholai. Sholai means thicket, of bamboo thicket. They belong to the Vedite group of aboriginals. There is a lot of discussion whether they are pre-Dravidian or early Dravidians. My Dravidian friends in Tamil Nadu will get upset if I say they are pre-Dravidian. So maybe they can be early Dravidian also. Shifting cultivation, food gathering, and hunting was their livelihood. They always lived in harmony with nature. They were basically nature worshippers. There is a big champak tree, which probably there is a picture, which is about 600 years old, and they sing and dance and get energized from the tree. So my own concept of tribal development started with curative health, saving people mauling by bears, snake bites, pneumonias. These were some of the emergencies I had to encounter, and I was very useful. Then I found Beyond the curative emergencies services, there was also the community health component, the whooping cough epidemic. So the concept of immunization, community health came. And I also had no pills for poverty. The land right issue was acute, and none of they were doing shifting cultivation, but there were restrictions on that. It was completely stopped. Hunting was stopped, so we had to fight for their land rights. I'm very happy to say that 20 years ago, we got land rights for all the tribal people in BR Hills. We also live in the midst of a biodiversity, hotspot of biodiversity. So it later on became what we call sustainable development. That's how to livelihood of the tribal people and the biodiversity conservation can go hand in hand. It cannot be the forest department's idea is that to conserve tigers, you have to displace tribals. So that's not necessary. Uh, my understanding of basic principles in tribal development is we have to live with the people, understand their strengths, their traditional knowledge systems, and build on it. We should have humility to learn from people, build on their strengths, and respect diversity. And the concept of bringing them to national mainstream doesn't, I don't agree with that. I think diversity is unique. They have to preserve their own identity and become part of the India. We also documented the traditional knowledge system about their forests, environment, traditional health practices, traditional agriculture, traditional knowledge about the forest. So we started mobile medical unit. Then the traditional knowledge, I just want to tell, they conduct deliveries in squatting posture. I didn't know about it. My first delivery, which was a prolonged labor, came to me, and I had, having trained in Bangalore Medical College, put an obstetric table to conduct the delivery. But the mother refused to lie down on the obstetric table. So then I found out from the traditional dai, they squat. In the squatting posture, they deliver the mother. So that day I was forced to deliver in squatting posture. Now we have enough research evidence to show that squatting posture is the ideal posture for mother to deliver. And why do you have these horizontal obstetric tables? They are more convenient for doctors and nurses. They don't get back pain. So now we have first we deliver in squatting posture. If there are complications only, we put them on the obstetric table. They also have sickle cell anemia, and we are working on that. These are the first tribal girls trained as the auxiliary nurse midwives. This is the hospital we have. I'm happy Abdul Kalam in the previous speaker also spoke about it. I also had the unique opportunity. One day I got a phone call from Abdul Kalam himself. He was in the DRD ward that time. Said one of the Punyatmas, one of the saints has told me to find 100 Punyatmas who can transform the country. I have heard about you. I'm coming there to see your project. So he came all the way from Delhi to our place, spent the whole day and looked at and gave us a lot of encouragement. And he also used to invite me to see the other Punyatmas whom he was discovering. At least 2, 3. Then he became the president. I thought he had forgotten. So we invited him for the 25th anniversary of our Vivekananda VGKK. And he agreed. He came all the way as president of India, spent the whole day, celebrated his birthday with the tribal children. And he has been a source of inspiration for all of us in our development work. There was no education in the BR Hills. I started with 6 children in a hut in 1981. 4 of them have become postgraduates. And Jadia is the president of VGKK. He is now the assistant, he is now the professor. Sorry, I had not updated. He is a professor of Forestry College. And several graduates, postgraduates have come out of that. We have many women self-help groups processing non-timber forest produce. We also organize community for fighting for their land rights. We have several megalithic burial sites which show that there have been habitation in BRLs at least 5,000 BC, 4 to 5,000 BC. So how did the civilization, whether they're the same as Soligas or different, we are now doing some research on that. but this is where how they used to bury a circle which demarcates the area, and a stone slab which covers and there is a feeding hole, annual feeding. This is a strange custom they had. Now they don't practice it, but we have 300 to 400 such megalithic burial sites in that area. Why have we have kept transplanted one in our campus? Because whenever hardcore forest officer comes and says that we have to displace soligas to conserve tigers, I show them this. If for 7,000 years people have lived together with tigers and elephants, why should we displace them? So we should find a solution for that. And after that, they stop talking about displacing tribals from the forest area. I also had the unique opportunity of working with the Andaman Nicobar tribes. I had planned for larger populations, and I was also task force chairman for planning for 6 crores of people. But to plan for Jarwas are only about 200, 250 people, and they live in the Andaman Nicobar Islands, nomadic, traveling from one place. So we had to design a health policy for them. It was a unique opportunity for me. And the other one is the Great Andamanis. Their number had come down to 28. They are now about 50. And they live in a straight island in Andaman Nicobar Islands. And there was a pharmacist posted, and he had a hazardous nemucilide syrup given there, which is banned in most of the Europe and America. But in India, it's available, but pediatric syrup is never given, the so-called nemucilide drug. So we made a policy how they should not be exposed to these hazardous drugs and basic communities, and also study their own traditional medicine and upgrade the skills rather than bringing alien systems of medicine. So lessons learned in tribal healthcare is decentralized planning and implementation, respect traditional wisdom and build on it, and the social determinants of health play an important role. So I wanted to be a doctor, but I had no pills for poverty. So I had to get into land struggle. I was in the jail with the tribals fighting for the land rights for 2 days. That's how we got finally the land rights. So social determinants are also very important other than the health. So all of our experiences, I was a member of the Commission on Tribal Health in India. Government of India had constituted it. Dr. Abhay Bang was the chairperson, and we made this tribal health in India and made concrete recommendations what type of health care we should have for the tribal people in India, but it is yet to be implemented. I started VGKK in 1981. Then I found leprosy, which was not there amongst the tribal people. Gradually, they're getting infected when they go down into Elandur, which is not the hilly area, the plain area. So there was hyperendemic for leprosy, 21 per thousand population. So I got trained in leprosy in Belur, and then started my leprosy work. And we have now eliminated leprosy in Elandur Taluk. We also worked on there's a peculiar type of epilepsy called hot water epilepsy in South India, in some pockets of South India. That is when they take hot water bath, they get seizures. So we had to work on that, and we also now control the epilepsy in that area. So the healthcare in India, so now the challenge was why I went to the VGKK and then to other parts of the country. Our motto is reaching the healthcare to the unreached. I started in what all I told, you might have heard about Veerappan. The younger generation might not know. A Veerappan forest dacoit was used to smuggle sandalwood, and also tuss was there. So we also work in Naxalite area in Orissa and some parts of the other states. And insurgency in the Northeast is also very common. So I will explain about insurgency a little more. So we work in remote hilly tribal areas where there is no electricity, no telephone connectivity, bad roads, cut off during the rainy season. Both public and private are not available. So that's when we were doing all this work, raising funds. So I met the health secretary and said, we are duplicating our work. We struggle to raise funds, but your people come and get their salaries and don't work. So the concept of public, they handed over, they identified the most difficult the primary health centers and handed it over to us, and we would run them. The partnership is we appoint our own staff who will be staying in that area, and they provide the whatever cost. They said they will give only 75% of the cost which they are spending. Later on, it became 90%. This is how the public-private partnership in primary healthcare started. We also partner with corporate social responsibility, and we also run several primary health centers through them. Our comprehensive primary health care is right-based empowerment of people for marginalized and health, preventive, promotive, curative, and rehabilitative services. So the institutional deliveries, this is I am proud of. So we have been now able to provide 100% institutional deliveries, safe deliveries, not in cow sheds anymore. So even in the village where I was born, we have a primary health center and we provide health services in that area. The IMR in several PHCs has touched the zero. Maternal mortality is also zero. So this is where one of the years it turned zero. It used to be 70. We have made several innovations.
Into a globe.
We have made several innovations in primary health care, process innovations in service delivery, appropriate technology, cost-effective ICT innovations, telemedicine, Logistimo for drug logistics, sensors for monitoring cold chain, drone for delivering emergency drugs, and empowering health workers with tablets and Android phones and EMCs, and also the Dell helped us to do that. This is the emergency care, which will take care of all the emergencies in primary health care, the protocols for emergency. We also integrated traditional medicine into primary health care. Instead of cough syrups, which have already several people were, as you know, last few months back, the cough syrups have killed children. So we don't advocate. My definition of a cough syrup is a colorful bottled sugary syrup, 4 to 5% alcohol, and some antihistamines, which are very dangerous. So instead of that, how can we grow Adatada Vasaka, a simple herb, which boiling that is a very good cough remedy. So those type of integrating traditional medicine into primary health care. Mainstreaming non-communicable diseases are also now increasing, how to manage them. Mainstream eye care, we also provide eye surgeries at 2,000 rupees per cataract surgery. Mainstreaming communication disorders, speech and hearing. We have a All India Institute of Speech and Hearing in Mysore. So I threw up a challenge. Why, it's no use having it at the district level or the state level. We should bring it down to primary healthcare level. We have worked out the details for how it can be brought. Now we have Janaushadhi, as you all know, but the idea started in 90s itself in VGKK and Karuna Trust, where we only wanted generic drugs, no branded drugs in our, and procure the generic drugs and distribute. Thanks to the government policy now, the Janaushadhi has only generic drugs and the costs have come down. We manage several Janaushadhis. Mental health program at, we are in the NIMHANS in Bangalore, is one of the pioneer institutions in mental health. But the Gumballi PHC is the first place where how mental health can be, again, was at the district mental health program was there, but nothing at the primary health care. So we demonstrated how it can be brought down to primary health care. We also have a Manasa for homeless mentally ill women. We rescue them and provide them psychiatric treatment. Management of cancers in a primary health center. We also have a health insurance model, which we did with the collaboration with the Government of India and WHO, and successfully demonstrated, which later on became the Ayushman Bharat scheme. We have several village health workers at the ASHA training modules. Community planning and monitoring is very important to involve the community to manage their own health. This is very, very important. Citizens Help Desk, mobile health clinics. This is an FRU, First Referral Unit for Emergency Obstetric Care. And then I got a phone call from the Secretary of Arunachal Pradesh. This was in 2005. He said, "We have heard about your public-private partnership. We will give you the most difficult primary health centers and you have to manage." So I went all the way to Arunachal Pradesh, and it was a learning experience. The southern tribes, except the Andaman Nicobar, they have bow and arrow. Most of the South Indian tribes are very peace-loving people. Not that Northeastern, all of them are there, but either they have a gun or a dagger with them. So we have to really little violent is there in their blood. So we had to work with them. It was a This was a bombing PHC. Even today there is no electricity. This how the bombing PHC was handed over to us. Wild boars running around. Only one D group was present to hand over. He was fully drunk. And now we have reformed. All the facilities are available in this primary health center. The infrastructure was also very poor. I myself stayed in a thatched hut in BR Hills for about 10 years. So I could motivate the young doctors. This doctor and the wife is a laboratory technician, and they stayed in a thatched hut till we built the quarters for them. Very committed people. There are committed people everywhere. These are the rough roads. We have to cross the Brahmaputra to go to various parts of Arunachal Pradesh. In one of the areas, they use the elephant to cross during the rainy season to cross the rivers. This is our symbol of reaching the healthcare to unreached. The village is cut off during the rainy season. There is a ropeway, which army builds it, and our ANM is using that to carry the vaccines to this remote area. And this is really the reaching the healthcare to the unreached. So these are all the states. It's scaled up into now 7 states all over India. We also have quality in healthcare. We have NABH accreditation. This Manasa for mental health program, we now both for men and women, those who are, this was another painful thing which I saw. Mentally ill people wearing rags and muttering to themselves, and children, people making fun of them, throwing stones at them. It's a very horrific situation in many parts of India. So we started this, we rescue them, take them into provide hygiene and the psychiatric treatment. They don't even remember their addresses. Once they discover their addresses, we rehabilitate them back into their families. So far we have succeeded. 95% of the people have been rehabilitated. About 5% have nobody, or we are unable to trace their families, and we provide shelter for them. So this is a very satisfying job, and we have done similar thing for the men now. We have worked with the Celco for the sustainable energy in our health centers. These are vaccine refrigerators, solar powered in many of our northeastern PHCs. We have a mobile unit for non-communicable disease. This is boat clinic in Brahmaputra is my dream project. I wanted to have a boat clinic. We have all the facilities, X-ray, we can conduct deliveries in this boat, and it goes to the islands of Brahmaputra where tribal people live. So it has been a wonderful achievement, and it's successfully running, and we have conducted several deliveries and managed several emergencies. This is the boat clinic details. Sorry, I am rushing it through. We had the opportunity. I also wanted to work in Nagaland. We got COVID gave us the opportunity. National Stock Exchange gave us the funding. And this is a CSR project, and we did very well in Nagaland. The Kavach project in Nagaland. These are the JSI funded project for COVID-19 vaccination. We vaccinated all the 1.5 million people in our primary health center during the COVID. We also managed the COVID-19 management. We managed at their homes, fever clinics, screening of health and education, diagnostic and testing facilities we had. We had TrueNot RT-PCR machines, home management, teleconsultation, referral services, all that was provided by Karnataka's PHCs. We made several innovations in COVID management also. Vaccination, I told you, that's when the idea that we need ICUs even in a primary health center. We started one-bedded ICU, especially COVID, at least to stabilize the patients. We need them. We also took up these 10-bedded ICU projects in 200 hospitals, mostly in Northeast and Karnataka. So we have provided 10-bedded equipment, ICU, telemedicine facility, and these are saving all the emergencies which we have. This is the second dream I had. I wanted to save lives, and through these 200 hospitals now, many lives have been saved. After working here, very briefly, I'll share. I also had the unique opportunity I was asked to become the chairman of the Task Force on Health and Family Welfare. So suddenly, from a few million people to I had to take the responsibility of 6 crore people in Karnataka and plan for them, especially for the poor. So we made concrete recommendations. We studied the health system in Karnataka, found out the gaps, and made concrete recommendations to improve it. And we made a health policy. As you find, we identified 12 major issues of concern, and corruption is on the top of the list. Our health secretary was very upset. How can you put corruption on the top of the list? Please bring it down, at least to the 4th or 5th. I didn't change it. I presented it to the chief minister. It was accepted. And I could not do much as a task force chairman on corruption, but we had a very proactive Lokayukta, one Justice Venkatachala. He was visiting the hospitals and finding a lot of corruption there. So I met him and gave him a copy of my report. So next day he called me, I identified corruption in health services, so why don't you join me as vigilance director? So I worked honorably with the government. For the judicial immunity, I was forced to take ₹1 salary from the treasury. I have those 48 coins, 4 years, which I worked with the government. And why I did that was it had tremendous moral strength. I could even involve the health minister who was involved in the procurement of dialysis machines. Instead of 5 lakhs, he had bought it at 12 lakhs. So I could even confront a health minister openly because of my ₹1 salary and my moral and inner spiritual strength too. And also procurement of equipment, drugs, and rampant corruption in the hospitals. First time we made the doctors pay back the bribe amount they had received from the patients. We have made many systemic changes for the good governance through Lokayukta. And now coming to the humanitarian philosophy, this is wonderful. So what was being good, also helping others as a value, as a goodness, as a value. It was a sort of passion in me. Only one of the Swamis identified it, Swami Vajananji identified that I have this goodness, and he encouraged me I wanted to give up my course and join the mission. He said, we had to complete it. And then he is the one who suggested me to join Mayavati. And so then it became a spiritual value. Of course, my mantra at that time, as soon as I first read Vivekananda, the mantra was, they alone live who live for others, rest are more dead than alive. And my philosophy of life was very simple. Every government spends used to be about 10 lakhs at that time, now it may be much more, on educating me. So it is my duty to give it back to society. All the knowledge which we get from the modern medicine and Ayurveda for thousands of years, now they have educated me, and then I have to give it back. If I don't do that, Swamiji calls me a traitor. So I didn't want to be a traitor. I wanted to be a good person. So having done this, Bhajananji also told me that we should have a personal philosophy of life, which includes the humanitarian philosophy. So I have evolved based on the Panchakoshas, an integral chart, which basically makes me live in harmony at various levels. I don't have time to explain all these details. Anyway, at the Annamaya level, I am part of the cosmos. So I take oxygen, give out carbon dioxide. If I don't give out carbon dioxide, I will die. If I don't get oxygen, I will die. So giving is also as important as taking. So we are all good at taking, but of course, carbon dioxide we usually throw out, but accumulating excess, we overeat and then accumulate fat in the coronary arteries will be a problem for us. So better we have to have a dynamic equilibrium with the cosmos and establish that harmony. Similarly, at the pranic level, with all the life forces, our own homeostasis, and living in harmony with the prana, and the entire humanity, society. Living in harmony with the society is also very important. This is called dynamic equilibrium. So this dynamic equilibrium was called, Bhajananji Maharaj has explained very beautifully as Ritha. Ritha is establishing this dynamic equilibrium, living in harmony with the cosmos, and somehow I have established this harmony, and very often in our corporate social responsibility now, the word is impact evaluation. They see what is the impact of the service we have rendered on the community, but nobody talks about what is the impact of the work done by an aspirant who believes in goodness, who believes in karma yoga. I think the returns to that is tremendous. Now I can watch. I may not have big bank balance. Of course, I was trained in Ramakrishna Mission, always lived a simple life. But I have tremendous spiritual. I have no insecurity. I live on the banks of Kaveri, and I have the joy bubbling up within me. What is that source of joy? I do not know. I have tremendous joy and peace. What used to be a sort of forced service as yajna has now become a loving service. I call it loving service because I feel oneness with all life, with the plants and animals and all human beings, and there is a great joy in serving. This is my loving service is the personal philosophy I have developed. I do it with joyfully and willingly, and I want to share that joy with all of you. Thank you very much.